Well, why don't we start by just having you sort of describe to us the current kind of biomarker landscape in RCC, and how these biomarkers have potentially shaped treatment, if any at all.
Yeah, absolutely. And I think the short answer is the majority of biomarkers probably haven't shaped treatment just yet. But I think there is room for some optimism. I think there have been certainly disappointments in the biomarker space in kidney cancer, but I think there are some sort of shining bits of light that I think hold promise for the future. And so the way I'd probably sort of break it down, at least in my mind, is there's sort of genomic biomarkers, things that intrinsic in the tumor itself, total mutation burden, neoantigens, these sorts of things. And while those have a certainly predictive effect in other tumor types, we know melanoma, non-small cell lung cancer, and there's a pan-histology approval for pembrolizumab with a high tumor mutation burden, that association doesn't seem like it really holds water for kidney cancer specifically. We've looked at, beyond sort of these aggregate measures of mutations, we've looked at individual mutations that might have an impact. And while there may be signals here or there of things that are, I would say, not inert, things that maybe have some impact, some influence on response, look at things like PBRM1 loss of function mutations or copy number variants in regions of chromosome 9p, there's nothing that's risen to the level of an actionable biomarker that's really going to impact for the patient in front of us should they get treatment X or treatment Y. And so I think genomic biomarkers have been really thoroughly explored, but still nothing that's sort of risen to the level of biomarker. The second bucket is transcriptomics, gene expression, and really looking at not individual genes, but signatures of genes that together sort of mark some behavior of the tumor as a whole. And for these, they're not just the tumor cells themselves, but the tumor and the surrounding microenvironment. And there have been lots of sort of forays into this space, but I think the one that really stands out to me as a sort of really most interesting is work done by Drs. Motzer, Rini, and colleagues at Genentech, where they really broke down clear cell kidney cancers into different molecular clusters or subsets based on their transcriptomic patterns. And so there were ones that were more angiogenic, there were ones that were more infiltrated, ones that were more proliferative, some ones that we still don't understand the biology, like small nucleolar RNA. But what they had seen, and this was in the context of the Emotion 151 trial, the Tezo-Bev trial versus sunitinib, was there appeared to be certain molecular subtypes that might be treated effectively with sunitinib, TKI monotherapy, things like the angiogenic subtypes, and others that really seem to benefit from the addition of immune therapy. And so, I think there's caveats there, of course, that it's the trial did not lead to an FDA approval. These are not using FDA-approved drugs, and so we still have to really validate, are these clusters real, and do they apply to have a predictive value for other therapies? But for me, that was the first kind of interesting point where it really did seem to distinguish outcome. And there's actually, as we know, trials that are already being designed sort of based on these subtypes, things like the OPTIC RCC trial, which having immune therapy still as a backbone, but whether you do an IO TKI and angiogenic subtypes or a pure IO-based approach in immune subtypes. So that's the transcriptomic landscape. There's other things which are kind of earlier stage, expression of endogenous retroviruses and these sorts of things, but that to me has the most sort of promise for the future, though, again, nothing that's ready for prime time. And the third bucket is maybe the oldest, which is histology and pathology, looking under the microscope. And there's been some things like PD-L1, which we know has lots of troubles and is probably not the strongest predictor in kidney cancer by any means, and has mixed results. But actually, the old looking under the microscope with the pathologist and looking at sarcomatoid histology, that's maybe one of the best biomarkers, honestly, for choosing an IO-based therapy. And we know from work from Dr. Tanier and others that looking at the Checkmate 214 trial of Nivo plus Ipi, that those patients with sarcomatoid histology really stand out as having some exceptional responses, a nearly 20% complete response rate, around a 60% overall response rate compared to the 40-ish% for the overall population. And so out of all of the ones that are probably actionable, it's the oldest, looking under the microscope at H&E and seeing the sarcomatoid histology, that probably is the most predictive at this point.
Thank you so much for that wonderful kind of summary of sort of where we are with biomarkers and sort of the current landscape. And you began to touch on the actionable biomarkers, and really in the present day, really the only largely actionable biomarker is patients with sarcomatoid histology who really should be receiving immunotherapy-based treatments and likely mainly Nivo-Ipi. But it'd be great for you to comment on what other actionable biomarkers I think are potentially out there, and maybe even share with us the story around PD-L1, and I think there was a lot of excitement and enthusiasm around that biomarker up front, and sort of what's happened with that biomarker.
Yeah, absolutely. And I think PD-L1 is something that has an intuitive place as a biomarker for anti-PD-1 based therapy. If you don't have the ligand for this inhibitory checkpoint, naively you wouldn't expect the tumor to necessarily be responsive to anti-PD-1 based therapy. I think there have been challenges that I would sort of group into technical and biological. Technical challenges are just practical, right? There's been history of antibody variation that sort of impacted staining and what you can call this PD-L1 positive and negative. There's been, not a pure consensus on what is important as a PD-L1 positive tumor. So is it having it on the tumor cells? Is it having it on other immune cells like myeloid cells? Some combination, and obviously there's scores that incorporate one or both of those. And so there's certainly technical elements that are still, I would put in the realm, not perfectly solved problems. Certainly advances in this, but not perfectly solved. The other are biological, which is PD-L1 is not a static marker and it's not homogeneous. And so it's not that you sample one tiny piece of tumor at one moment in time, and that is universally reflective of the PD-L1 status for that patient. We know it's dynamic. It's an interferon gamma responsive gene. And so as immune infiltration differs, either over time or over space, so in different spots of the same tumor or in different tumors within the body, there will be different levels of PD-L1 expression. So capturing this one moment in time with the biopsies is a challenge. So those are the challenges. And so I think in RCC, it's my sort of impression of an aggregate of these studies is that, again, PD-L1 is not inert. It's not that PD-L1 has zero impact. And I think as we look across studies, especially the more modern checkpoint therapy trials in the front line, I would say we see some enrichment in my eyes for PD-L1 positive patients, slightly higher response rates, better responses, better survival, these sorts of things in that PD-L1 positive population. But it doesn't rise to the level of a discriminant biomarker. It's not something. What we want is, when we talk about biomarkers, really what we want is EGFR, right? We want something where we get a test and it says positive or negative, and we know that if it's positive, it has a high likelihood of working, and if it's negative, it's probably not worth giving. PD-L1 comes nowhere close to that level in kidney cancer. I think that's been the challenge. And when we think about both the technical and the biological issues, I think it kind of makes sense in that context.